I'm going to be speaking a little bit today about something, if we take a look at what Mike showed today, how exciting it is. Really, truly exciting to be a part of dentistry today, especially if you're involved in the surgical regenerative side of dentistry, because you have all these incredible tools at your disposal. I mean, you can even see Mike's evolution from really block grafting into biotechnology and bioengineering has been incredible. But with these technologies and with these techniques, I've always felt that you needed an idea, a plan on how to solve a puzzle, how to solve a riddle. And with those things, you need certain fundamentals. Obviously, Mike's showing you incredible technique, and that takes years to develop those techniques because the materials by themselves will not work if we don't treatment plan and create the correct path and be able to do the surgeries to allow these materials to work. In particular, an area that I'm going to focus on today is an area that I'm sure we've all fell into a dilemma. I don't think there's anybody in this room who's been doing implants for any significant amount of time who hasn't fallen into the trap, what I call the Bermuda Triangle of implant dentistry, of tooth replacement dentistry, is replacing the central and lateral next to one another. And I call that the central and lateral dilemma. I'm going to be speaking a little bit about options and interdisciplinary solutions in regards to this particular arena. As we mentioned, that a lot of what we see here is group thoughts and sharing of ideas. Obviously, I couldn't be up here today if it wasn't for the group that I work with in Atlanta for the last 21 years, Ronald Goldstein, David Garber, my brother Henry. We also have on our team several other dentists that really round things out, 2 prosthodontists and an oral maxillofacial surgeon. But also the sharing of ideas, not just with my partners in my office, but with mentors and colleagues from around the world, many of them sitting in this room, but certainly people who have shaped my career in a lot of ways. Mike, who's really been able to take me on and show me really how to organize my thoughts related to bone regeneration. Dennis Tarnow, who really focused me on aesthetics and looking at research, clinical research. Eduardo Anitwa, who really opened my eyes up to the potential of blood-borne bioactive modifiers. And Stephen Chu, who really was a colleague over the last few years who involved me in some research related to extraction site and implant replacement. Mike talked to you about the meeting that we do together. It's really, to me, every 2 years has always been sort of something I look forward to. It is the meeting that I think is the most significant that we do. It's 3.5 days. This will be the 8th one we've done, the 6th in the United States. We've done 2 in Europe, and certainly welcome all of you if you're interested. I know that Tyler over at the Dental XP booth will have some brochures, and certainly welcome any of you that are interested in learning more about what Mike was showing you in a more intensive 3.5 day session at the Ritz-Carlton Hotel in Orlando, Florida. Let's start with the dilemma that, as I said before, has been one of the areas that I feel has been difficult to solve. It has inspired a lot of thought and a lot of clinical research and subjective evaluation of my own cases in my office and some ideas of how to resolve these issues. This case was sent to me by a colleague, very esteemed oral maxillofacial surgeon, not in Atlanta, who asked me, what would I do in a case like this one? A healthy 39-year-old female with a history of a failed apicoectomy with subsequent implant failure on top of that of the left lateral incisor. Number 1, the patient desires an aesthetic option. Number 2, has a high smile line. And number 3, the left central incisor has a shortened root from prior orthodontic therapy and orthognathic surgery. Let's look at this case that was sent. And this is one of the amazing things about being involved in a digital world, is that people have access to you and you're constantly looking at this. And it's not like this is one of the easy ones that come into my email basket and I say, oh, this is easy, just do this. Use this implant, use this bone graft material, use BMP. This requires some thought. Let's hold this in mind as we go through all the relevant material that allows me now to look at this with a more comfortable and reasonable assessment that I can then provide my solution or potential solution. When we talk about interface development, we've mentioned this and really introduced this to this Seattle Study Club many, many years ago. Not as much implant site development, but interface development. The interface between the lips and the gingiva, the bone and the implant, and of course, eventually the abutment and the soft tissue. Related to a single tooth, it's challenging, certainly, especially in the aesthetic zone, but we've been able to be very predictable in managing a single tooth. But what occurs when two teeth next to one another in the aesthetic zone are lost? Invariably, what occurs is a different anatomical situation. The bone loss is not only buccolingual, it now becomes vertical, especially in the interproximal arena. Let's look at a case that I was asked to be involved in treating. This patient had gone to 4 different people, came to me, was the wife of a medical doctor. Implant was placed in a lateral incisor, had failed. They bone grafted it, placed another implant, it failed again. The problem in this case was not only the loss of the bone around the implant site, was the subsequent bone loss on the adjacent natural teeth that are now extremely mobile, and the bone loss is significant. We're probing 12 to 15 millimeters from the contact point. Now you're looking at a patient who came in for a single tooth, who's now been told by 3 different doctors that the likelihood is that now she's going to be losing 3 teeth or having to replace 3 teeth. So we start to envision, as Mike said, looking at all the available technologies to first diagnose the case. Bone sounding, something that we introduced in 1998, the interproximal height of bone. Understanding that we have, these are 15 millimeter Michigan probes, that you are more than 15 millimeters from the contact point on the canine. You're roughly 14 to 15 millimeters on the central incisor when you get down to bone. Can we grow bone on a zero-wall defect, on natural teeth that are mobile? How much of this can be attained in an aesthetic form? So obviously teeth are lost. We're going to have to now plan this case. It's a type 3 defect, a vertical defect. We're going to use a combination of gingival grafting from the palate, autogenous grafting of soft tissue, and in addition, I'm going to use a putty-like material, something that has structure to it. And this is made by a particular company. It's a calcium phosphosilicate. It's a bone graft putty, and it sticks around for a while. The average reentry time of 5.4 months in one of the research studies in vital bone, about 50%. So you have about 5 or 6 month time frame, and that's what we want in terms of supporting the vertical. But I don't promise the patient, I don't overpromise in these cases that we can completely reconstruct the deficiency. So here's the putty being applied. It's in a syringe applicator. A lot of these techniques and tools are great, but as we said before, they're just a small part of the overall concepts that we're going to apply. So the putty now gives me some structure vertically. I can then utilize, as Mike has shown you beautifully, we use very similar materials. This is PRGF, or plasma-rich and growth factors, something that comes from BTI and Eduardo Anitwa, who introduced us to it. And now that goes over the top of the putty bone. We secure the connective tissue to the labial flap, and then, as always, as Mike mentioned, tension-free release of the flap, primary closure, allowing some space. That connective tissue is now over the top of the ridge. So I don't have to completely manipulate my mucogingival junction vertically. The second thing that can destroy any surgery is early loading of the surgical wound. So I typically will use either a resin-bonded prosthesis or a tooth-borne removable prosthesis, such as this one. This is an Essex appliance, just with denture teeth that are secured inside the vacuform matrix. This patient lives up in Connecticut. I get a picture from her dentist. General dentist actually went to dental school with me at University of Pennsylvania, and I received these photographs just recently. And he said, Maurice, you know, I don't really know what she looked like when she started, but I just made her a flipper appliance. It's 4 months out. I'm going to take a CT. When do you want to place the implants? And one of the first things that I said to him is, it looks better than I expected. Why don't you send her to somebody really good up there? Because at least right now, I'm looking okay. He said, but she loves you. He said, you one surgery, you did everything, and she doesn't want to go over there. She had bad experience. I said, listen, I'm going to look and ask my friends, and I'm going to find people in a 60-mile radius that are excellent surgeons. We're going to send her over there. But I'd like it if that patient who has that kind of protoplasm doesn't come back to Atlanta anytime soon. So look at the process of evaluation. Interproximal height of bone is measured. We have the cone beam CT, multiple failures, scar tissue. But we're using these techniques to try to build the case back. But the best thing is that by identifying the case, I don't overpromise. I told this patient the likelihood is I can never attain the result that you see on the right screen. That she should expect that she's going to be restored more than likely with artificial gingiva to reconstruct the defect. And you see where we started, and the central image is the CT scan on the far right, the early healing of that putty bone at 4 months. And you can almost see how that bone is starting to resorb, and really thinking about it maybe in 7 to 8 months, somebody or myself having to go back and place implants. But let's talk about this, because it's not a new challenge. We think about this and say, oh, you know what? It only existed in the age of implant dentistry, but it did not. Let me share with you my own failure. And this morning, we saw the lecture was beautifully done about dealing with failures. I can tell you, I think I prepped the wrong tooth in dental school, and I did extract the wrong tooth down in Atlanta when I was first there. So I think I did everything, and one of the things that he talked about earlier today, I think I've done both of those things. This was my case. A patient came in to see Dr. Garber. I just got to Atlanta. I was there 2 or 3 years. She was the vice president of Home Depot in Atlanta, not somebody who's not that important. He said to me, can you reconstruct the Pontic site? She's missing the papilla. I said, I just went to the American Academy of Perio. They had this special lecture on regenerating papillas. Let me do it. Ooh, 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 let me do it, David. He walks in there and he starts explaining to her how he recruited me out of Philadelphia. I went to University of Pennsylvania, Perio program, where he went, and I'm the guru of papilla surgery. I go in, do the surgery, and that's what it looked like about 6 to 8 weeks after the surgery. He calls me in the room. He said, look at what you did. I said, just as Bob Uecker once said, just a little outside. He says, so I looked at him and I said, so what are you going to do to fix it? But these dilemmas exist, and I'm going to share with you kind of things that happen. I looked at this case as a surgeon because I wanted to use a technique that I saw in a lecture. This is true. I'm telling you exactly what occurred. But in the process, I didn't completely understand that the bone that I didn't probe, that I didn't know was missing on the mesial of the lateral incisor was missing. When we took a PA and I bone sounded, I said, ha, like Columbo. I said, David, I think there's a reason. It's not just that I'm a bad surgeon. I was also a very bad diagnostician. It's like the perfect storm. The bone wasn't there, therefore my graft didn't have the support of periosteum and vascularity, but I think we can fix it. Section the bridge, I extrude the tooth, and I bring back the papilla. So what I failed to do diagnostically, what I failed to do as a periodontist, I was able to correct with simple orthodontics. And by the way, what's really interesting, this is 20 years this meeting's been undertaken. My first lecture at the Seattle Study Club, for those of you who've been around that long, was 1995, and my topic was orthodontic extrusion. And I remember many people sitting in that room that day saying to me, It's not practical. My patients would never say yes. And now today, all over the world, I see people using it routinely, like picking up a razor in the morning. It's wonderful how things evolve and change. So we can take a disaster and we can correct it. So again, it's not just about the materials and the biotechnology. It's about diagnosis, options, selecting the least invasive and the method that will give you the highest predictability. The literature goes back quite a bit. Certainly for us it does. In 1998, we published our article on the interproximal height of bone, and we classified it as a type 1, 2, and 3 case, depending on severity. In 1993, again, 20 years ago, my brother and I published an article that looked and talked about classification of extraction site defects. At the time, it was the first article that classified extraction site defects. Today in the literature, you can find, I don't know, maybe another 100 classifications of an extraction site. I didn't know an extraction site can have that many classifications, to tell you the truth. But it gives us an opportunity to look at things in a similar vein so that we can start to understand together that one doctor in one part of the country can talk to another and say, I think that this is a vertical or type 3 defect. So we can start, it's almost all of these classifications are somewhat similar. So they're not that different, and that's a good thing. In 1993, we published the article on extruding teeth. In 1996, we talked about these things. And the reason is, when you look at something that's effective. When I was in college, I played basketball at the University of Binghamton. And in one game, right before halftime, I threw a basketball almost 3/4 of the court, and the ball went in. To my amazement, the ball went in. Now, immediately everybody starts jumping, and everybody jumps on you, and you act like, I knew it was going to go in. Why are you so surprised? Effective, if you look at the definition, is capable of producing an intended result or having a striking effect one time. So it is effective to throw a basketball 3/4 of a court, and the ball can go in. But is it efficacious? Effication marked by qualities giving the power to produce an intended effect many times. I implore you that when you look at your cases to think of being efficacious, that on the average patient, by the average clinician, on the average day, that we can all attain a high level of success. I'm not going to be able, if I took that same shot probably another 100 times, more than likely I'd miss it almost every single time. But it was effective to do once. Let's try to look at being efficacious. The central lateral dilemma. Is it a dilemma? These are real cases. These are not somebody else's. This one came to Atlanta. This was before they were going to get married. A friend of mine in Florida sent this one over to me and said, what can you do to help me? Bone grafts are done. Implants were placed. Free gingival grafts were done. What can we do now? I said, you can tell them not to get married so soon. These are cases that I see every day in my office. A couple of these are my own cases. Some of them are referred. But these come into my office. And I'm sure many of you have seen similar cases. And we talked about this a few years ago at the team meeting where we kind of introduced Christian Coachman to this group and how we started to fix some of these problems with artificial gingiva. This is a common theme in clinical practice. You're going to be asked to deal with these types of dilemmas where you're going to be losing teeth on one side of the midline. So let's first define the dilemma. Single tooth defect, the reason it's so successful, simply put, you're maintaining the periodontal ligament and attachment of the adjacent teeth if they're healthy. You also have those teeth available to manipulate with orthodontics if they're not completely healthy in terms of interproximal bone. When you lose 2 teeth, and these are skull specimens of patients I didn't like, you're going to lose that very, very important interproximal bone because when the tooth's gone, the periodontal ligament is not there to supply vascularity and attachment, that bone's going to be lost. No matter what you do, by the way. You can do BMP, LSD, whatever kind of thing you want to do, that bone's going to go. And when it goes, that's what the foundation of that area is going to look like. You're going to lose vertical, and vertical is very hard to retrieve. Look at this case. Bone is lost. The patient comes in as a second opinion. Immediately, first thing I'm thinking is not that far a drive to Tampa. I usually send all of these to Mike, and with a little card saying, hope it's sunny down in Florida. And unfortunately now he starts sending me some of those also back to me in Atlanta, and it's kind of fun. But these are difficult cases, and some of the reasons are that the cases are treated without a proper diagnosis of the interproximal bone. This bone was lost on the lateral before the implant was placed and failed in the central, causing this type of problem now. And the lateral incisor has to be addressed as well. The interproximal bone obviously needs to be addressed because in a patient with a high lip line, she's 35 years old, this is going to be an issue, that central lateral issue, where you're going to try to compare those two teeth on the left side to the natural teeth on the right side of the midline. So that loss of papilla, just a couple of millimeters, changes the shape of the teeth, changes the contour, changes the aesthetics. It may seem like a little bit of a problem, but it's actually a very significant problem. Look at this case that was restored. Patient comes in, this is a year after he was restored. High lip line, and I can tell you, he comes in and he says to me, first thing, honestly, my friend told me to come to you to do the case, but I found a dentist that was a lot cheaper. But now I understand my problem, I'm owning up to it, and I'm willing to pay the cost for you to do it right. So I said, there's not enough money to be able to do that one right. And the problem is, what do you do now? You talk about how can you repair this. A lot of our patients don't understand. Even some of the clinicians that are doing the cases don't understand what the possible ramifications are. Should we prepare the patients for this potential? Should you do it if you don't understand that these are potential ramifications? Why does it happen? Another unhappy customer. Take a look at the area that you're working in. This is what it looks like anatomically. The reason you get away with implants between the canine and the lateral, or between centrals, is because the bone in that area is quite thick. You have about 3 millimeters of space at the midline. You got about 2.5, 3 millimeters routinely between the canine and lateral. But look at the area between the central and lateral. It's typically very, very narrow. So if Dennis Tarnow, who you've invited here and is incredible, and he's done his research telling you need at least 3 millimeter separation, but God said, I'm only going to give you 1 millimeter, you got to come up with another idea. You got to come up with another solution. You have to come up with strategies. Take a look at this on the light. This bone is mostly cortical bone. It's not very cancellous, doesn't have a large vascularity. And then on the facial, we know the recent literature says to us what? That the labial bone typically is less than 1 millimeter thick in the anterior maxilla. More than 80% of the cases that were evaluated on cone beam and intraoral measurements with digital calipers were less than 1 millimeter. So you're dealing in an area, it's like I'm not a guy who, I'm not a ship captain, I don't run too many yacht charters, but that whole Bermuda Triangle thing, if you're going to, if you're going to have to take your boat into those waters, maybe you're going to end up with some problems. So if we take a look at a case like this one, patient has now a failing bridge. It's going to involve the central lateral area. She's unhappy with the bridge, the aesthetics of the bridge. And we start to look at the case. Tooth number 8 is missing. We start to evaluate the interproximal heights of bone. We realize that there is going to be an extraction because of resorption at the neck of the tooth. And we're going to end up having to replace these teeth. Tooth number 9 is resorbing. And if we look at this case, look at where the papillas are now before we start. You have very long teeth and very long contact points. I know that I'm already dealing with not only a buccolingual and extraction site maintenance case, but a vertical type 3 ridge defect. So what I'm going to do first is to use what's been around for a long time. I'm going to turn a type 3 case into a type 2 case by just putting some braces on and slowly erupting the entire bridge. Not just one tooth, but 3 teeth. And by the time I erupt the teeth, after 3 months, and I stabilize them, patient comes in, I take the brackets off. You can see that as I extruded the teeth, the bone and the gingiva came down with it. And that extra gum is going to work on my benefit and for the patient as well. And the bone underneath is going to allow us now to treat the case as a type 2 labial defect, which is much more predictable in terms of bone regeneration. If we take a look at this with the smile line and the interface, there's that amount that we've created orthodontically. Now, can we do it surgically? Yes, but it's not something that I would say is as predictable if you're able to use orthodontics. So now I'm going to go ahead and proceed as a surgeon here and take a look at the bone levels of the teeth that were extruded. The lateral and the central, actually the bone has come down the same amount as the soft tissue. And more importantly, if we take a look at the defect around the central, we certainly have to deal with that defect buccolingually, but more importantly, if I probe interproximally, the interproximal height of bone, the bone is present on those teeth. We've enhanced that particular area. So now I can extract the tooth with the resorptive defect, and I can deal with a buccolingual defect on the right central and an extraction site defect on the left central. We can get back to doing the procedures that are more conducive to the type of dentistry that works for us. So we're going to deal with a labial defect and a labial plate. Implants are going to be placed. We're going to place 2 platform switch style implants here to be able to enhance the space between implants. These are 2 ankylose implants. We're going to maintain that 3 millimeter distance, as we talked about earlier. We're going to use mineralized bone. As Mike pointed out, we're going to mix it with a bioactive material. We're going to cover it with a series and layers of fibrin, autologous fibrin from the blood, and then over the top, a collagen barrier that's secured with pins. We're going to cover over the top of this, and we're going to release the flap. Temporary bridge is in place, and you can see that with the implants there, our intention was to secure bone all the way above the platforms of the implants. When we come back at 4 months, you can see the pins are going to be removed, but you can see the amount of augmentation that's been achieved using this bioengineering concept that Mike pointed out so beautifully. At this point, I'm going to thicken the soft tissue utilizing an acellular dermal matrix. This is perioderm from Dentsply. I'm going to add that in to thicken the tissue and allow myself a few months for that tissue to integrate. And now I took a case that was a type 3 case, and now I can simplify the final part of the uncovering. I have enough tissue, I have enough thickness, I have enough bone height. I can now use a punch uncovering, tissue punch, place my impression copings. Dr. Garber did this, send it to the laboratory, and the case was restored by Guy Cabril. Look at the soft tissue in terms of the soft tissue scallop. We're going to use some of the tissue at uncovering, always to use it a little bit just to further augment that area around the implants. No reason to discard the tissue that was uncovered with a tissue punch. And you can see these are nylon sutures, and then at approximately 6 or 7 days, you can see when the sutures are removed that we have very, very nice thickness of keratinized tissue in front of the implants. Facial view, buccolingual view, maintain the contour. Is it important to thicken tissue? Not just for aesthetics, not just for maintenance of the sulcus, it actually has an influence on maintaining crestal bone around our implants. If we look at this study by Tomas Linkivicus, I recently had an opportunity to have dinner with him at the EAO meeting. He's a young man in his 30s. I expect a lot from him. But he said to us, if the tissue was 2 millimeters or greater, you had at least 1 millimeter more bone maintenance around the top of the implants. And this was a prospective study done on clinical cases and patients in the university. So tissue thickness maintains bone, not just maintains the health and the aesthetics. Crestal bone changes around platform switched implants. 2 platform switched implants allow for more distance from the restorative materials and the prosthetic components to the adjacent teeth. A recent article by Vela and his team suggested that when the tooth implant distance is less than 1.5 millimeters with a platform switched implant, you can still maintain the interdental height of the bone and soft tissue on the adjacent tooth. This is something that goes back many, many years, where we used to hear it had to be 1.5 millimeters, something that Esposito wrote about back in the early 90s. So we keep the distances that we learned. We keep the tools that we've learned. And we can use orthodontics and periodontics, bone grafting, prosthetics, and good laboratory technique to enhance the final result of these cases. What other tools do we have at our disposal? Look at this case, thin scallop biotype. Restorative dentist doesn't work in our office. This is a referral from about 30 minutes out of Atlanta. And this gentleman wanted to have the teeth removed and implants placed. Highly scalloped gingiva, triangular-shaped teeth. This is a dilemma. We thought about this and a few years ago introduced a concept that I was very excited about. I actually did this technique yesterday on video for the first time, and I'm probably going to put it on Dental XP soon. The reason the teeth work so well is because we have supracrestal fibers that are inserted horizontally into the tooth, Sharpie's fibers and connective tissue. Around implants, we have fibers that are inserted parallel. Therefore, we probe easier and deeper around implants because we don't have those same fibers. So what happens if rather than using implants next to other implants or extracting a tooth and having to do socket preservation, which I actually don't believe that's an oxymoron. We never completely preserve a socket. We preserve most of it. But how about if we don't extract the tooth at all? We just remove the crown of the tooth. And we maintain the root 1 millimeter above the bone. It would retain the socket completely. And it would retain those supracrestal fibers that can maintain the soft tissue. And this is something we introduced with our friends and colleagues in Japan, Tom Ishikawa, as well as Aki Funado. And I have a lot of my friends that come from Japan that I've had the opportunity of working with. And we extracted the central incisor. We placed the implant, left that gap, and that's probably going to be discussed this week with other lecturers. We're going to graft it. But in the area of the lateral incisor, we submerge the root and we place a connective tissue graft. This is not something new. Submerging roots started back in the 60s under dentures to maintain the alveolus. At 3 months, here's the implant on the central with the healing abutment, and the area of the submerged root has been completely maintained, both vertically, horizontally, and most importantly, the interproximal peak of bone to support the tissue in a very highly scalloped individual. Again, now I can prepare the implant and the ponic site for my partner, David Garber, who's going to restore it. Essex retainers made, and then the 2 crowns. This is a 2-year post-op, maintaining a very high interproximal scallop, utilizing a submerged root technique. Is it new? We published it in 2007. I presented it at this meeting. It was my first lecture on submerged roots, occurred at the Seattle Study Club meeting. You can start to see there's a theme here over the years. I give you guys my best stuff. I don't hide it. So, Michael calls me up and said, you better have something interesting to show. This is the article that was published in JOMI back in 2007 that talked about a series of these cases. We followed now in my office 54 cases since 2007. There's only been 1 case where we had to go back in and extract a tooth. Now, more exciting than that, take a look at this case. This is one of the cases we did. At 3 years, she comes in, and the bridge got loose. As a matter of fact, one of the people that's maintaining this case for me is part of the Seattle Study Club network. And he says, Maurice, you got to go take a look next time she comes in. He sends me the patient. The bridge was loose. We're going to re-cement it. I walked into hygiene, took a PA x-ray, and then I highlighted it, as you see here. And you can actually see something quite amazing to me. It appears to me that there's bone and cementum that is growing over the vital roots. We didn't just submerge roots that were endodontically treated, we submerged roots that were vital. We did not treat them endodontically. And look what happened. 3 roots in this one case, all of them survived. As a matter of fact, half of the patients we treated with this technique were vital roots. Vital root submergence, Dr. Slama? What scotch are you drinking? Well, it's not something new. Everything that we come up with, we usually like to say we stand on the shoulders of those who came before us. No, we steal and pillage from them. So, where did I get this from? Did it exist before? No. I didn't get it from myself. Journal of Perio, 1989. Bowers did it around teeth that he treated with guided tissue regeneration and membranes. And he said vital roots underneath the flaps retained their vitality and cementum grew above the top of the prepared root surfaces. A greater percent of positive regeneration was attained of the attachment apparatus, and all component tissues occurred in submerged defects. No extensive root resorption, ankylosis, or pulp death was observed on submerged roots. So even if you don't believe me, because I kind of have a history of drinking some very good single malt scotch, this is coming from a reliable source. The conclusion, look at this study from O'Neill back in 1978. You got to really go into the literature. Submergence of roots for alveolar bone preservation. This is 1978, the conclusion of the article. This procedure should be considered as an alternative to extraction of key teeth in an effort to preserve alveolar bone. So, one implant with a submerged root ponic is another option. We have the ability, we published this again with our friends in Japan, Tom Ishikawa in his case, where he took a huge defect and talked about 3-dimensional bone and soft tissue regeneration of these large defects, and he came up with tremendous skill to be able to do this on his case. But how many of us can perform this on a routine basis? Effective versus efficacious. Would I promise this on a patient that I can attain that kind of result? Multiple surgeries. Let's look at this case. Very large defect, wouldn't you say? Just a little bit. This patient, again, history of failures, a very large defect that now caused the loss of the lingual plate of bone. We have a 0-wall defect in 9 and 10. We tried everything. In this case, we used allograftic block, PRGF, mineralized bone. We went through the process of vertical augmentation. And if you look in the literature, Esposito's work back in 2009 suggested that when he looked at all the different literature and research projects on vertical and horizontal bone augmentation, he said that he found that the complications were especially true for vertical augmentation. They should be considered common. So we look at this case, secondary exposure, implant is placed. We did a soft tissue augmentation of the ponic, but in the end, Christian Coachman, myself, and David Garber realized that we came up short. And we had to come up with an idea for managing it. And another idea that was presented again at this very meeting in Hawaii a few years back was the utilization as an alternative therapy, prosthetic gingival reconstruction. I know Christian's been back at this meeting, and certainly he stays very close to us at our office and is involved with us very often as well to this day. 1 year post-op of utilizing artificial gingiva, pink composite over pink ceramic. Look where the defect started, and obviously one implant with a cantilever ponic and artificial gingiva is another option for those types of severe defects, and sometimes we start that way. And if we take a look at the way she looks today, you look at the left side versus the right side with some of these different artificial materials that we use, and certainly composite resins. This was Gradia from GC and a talented ceramist. We can actually achieve these kinds of results. And for a young lady like this, I don't want to promise more than I can achieve. So I want to start the process of building this into the equation. And we published a 3-part paper in Quintessence in the IJPRD of how we address those particular situations. 3 years post-op. People ask me all the time, how are those cases doing? Remarkably well. We have only had to re-veneer the composite on a couple of cases. We've done over 60 of these cases. And we're going to be publishing on the follow-up with Christian pretty soon, maybe in the next year or two. Another option, we have a patient, this young man in Atlanta was mugged on a school bus, listen to this one, for being an honor student. Yeah, it's gotten that bad. Because you do good in school and you're a good kid, you get beaten up. So we decided, I heard about this on the news, it was a special story, we got in touch with the news agency, and we actually asked to treat this patient pro bono. And when I looked at the case, the first thing I said to David Garber is that I'm not so sure I can build up the defect purely surgically. This is a young man, he's just 17 years old, 18 years old, he's a senior in high school. I decided to orthodontically move the canine into the defect environment. And that way, I went from a two-tooth defect to a one-tooth defect. I removed the central lateral dilemma using orthodontics. And now I have a one-tooth defect that I'm dealing with that's buccolingual. I removed the vertical component, like I did in the other case with extrusion, but with bodily movement. Now I can put a block graft, we can do all the things that we talked about earlier, come back, place the implant, use the bioactivity and bioengineering, place the restoration in there, shape it, and we have an implant with canine moved into the lateral position. So we have the option of doing all these interesting things, of moving teeth around so that we can end up with a result like this one. In the end, a little bit of bonding on the right central to close a little bit of that black triangle, but for the most part, I think a very effective result. The canine in the lateral position, it could be composite bonded or veneered for better aesthetics, but overall, look what was achieved. We maintained that problem. We maintained the area with not a vertical defect, but managed the horizontal component. Turned a two-tooth defect into a one-tooth defect. Turned a type 3 defect into a type 2 defect. Back at the ICLI meeting in 2012 last year, I said something that I think is very relevant. It's very obvious to us still, to this day, even though we replace a lot of questionable teeth all the time with implants. If you save the roots, you save the bone, you save the tissue. Think about that. Save the roots, save the bone, save the tissue. So if you're going to extract a tooth, take a couple seconds to think about it. Can it help me by first orthodontically moving it, then extract it? Or can it help me by preserving the socket by submerging it? You may be surprised. You take a case like this and a 3-unit bridge, and you end up with a very, very nice result. And you get back to this case in treatment planning. This is the case I started with you. I know you guys here in Seattle Study Club have these treatment planning sessions. Well, here is the case I started my presentation with. What would be the treatment plan that I proposed for my colleague down in Louisiana? I said I would erupt the central incisor. I would do connective tissue for root coverage, ovate pontic for the lateral, an implant in the central, and I cantilever the lateral incisor. Or you can move the canine into the lateral position orthodontically and then have a single tooth defect. I based my treatment plan decision not on guesswork, not on how good a surgeon I am, or Mike is, or any of the many, many gifted surgeons in this room, but based upon sound biological rationale and principles on diagnosis, on planning the case. If the patient says no to that, I can live with that. I can live with that, but I want to offer them that. So as a conclusion, and if any of you haven't been writing, here's my conclusion for my lecture and from Mike and I's lecture, where we really tried to share with you bioengineering, biology, and surgical techniques in the afternoon. In the second part of the lecture, obviously talking to you about strategies, theories, concepts related to diagnosis and treatment planning. Number one, you can place 2 implants for central and lateral. I'm not going to tell you not to do that. There are small diameter implants now and platform switched, but you must expect that you may lose that interdental papilla. You may have a vertical deficiency. In a low lip line patient with square teeth, rectangular teeth, it could be acceptable. The concerns are anatomical and biological. Look at the skull specimens I shared with you. Number 2, implant with a cantilever ponic. Yes, you can do that. Extract the tooth next to it and do a socket graft. You can do number 3, 1 implant with a submerged root. Number 4, you can do an implant with a bone block to support the ponic. And certainly that is possible as well. Number 5, you can do an implant with a cantilever ponic and artificial gingiva, something, again, that we showed you here at this meeting only a few years ago, and the one that we published on with Christian Coachman. Or, number 6, you can move a tooth, the canine, or some cases it may be possible to move the adjacent central incisor over the midline to create a 1-tooth defect rather than a 2-tooth defect. So, recall again, effective versus efficacious. We all want to be efficacious with what we do, and that's based on diagnosis, sound treatment planning. I'd like to thank Michael for always being nice to invite me, and certainly it's a pleasure to be on the podium. Anytime I can share it with Mike, we'll have more of an opportunity to do that in June. I certainly welcome you for more information on that. You can go to Tyler out in the exhibit area, and for my group in Atlanta, certainly couldn't be here. I thank you very, very much for your attention.